Hello, everybody. I am Todd Simmons, Executive Director of Jefferson Performing Arts Society, and I'm very excited to focus our roundtable today on mental health and the mental health community. We recently at JPAS closed our production of One Flew Over the Cuckoo's Nest and will open Arsenic and Old Lace on February 26th, both productions which focus on mental health but through very different lenses. With COVID today and everything that's going on in the world around us, we thought this would be a great opportunity to pull together a panel to talk about how perceptions of mental health have changed over time, where we are today with perceptions and treatment, and where it needs to go in the future. So, with that extremely broad format there, I'm going to ask our panel to introduce themselves and tell us just a little bit about us, and then we'll be off. So, Sean, do you want to start?
Yes, sir. Hello, everyone. My name is Dr. Sean Gibbs. I'm a clinical psychologist, the program coordinator at Dillard University. Um, I'm happy to be here, excited about this topic. The idea of mental health and the perception of mental health changing over the history and how it affects our culture is a particular topic of interest of mine. So I'm really excited to talk to the um, clients or patients or individuals who are experiencing the mental health system at this moment in time. Thank you very much.
Thank you very much. Janet, would you like to introduce yourself, please?
Sure. Hi, Todd. Hi, everybody. Thank you so much for inviting me to the panel. My name is Janet Hayes. I began a nonprofit organization, Healing Minds NOLA, about 3 or 4 years ago to look at exploring and creating alternatives to incarceration, homelessness, unnecessary repeated hospitalizations and death for people living with untreated and undertreated serious mental illnesses. So we're mostly an advocacy organization, but occasionally sometimes policy needs implementation. So we do that too. I work at the state and local and federal levels on policy initiatives to remove barriers to treatment and care for this specific population that we're interested in. And thank you again for inviting me.
Thank you for being here. Now, Dr. Robert, would you introduce yourself?
Sure. Thanks, Todd, for having me here. It's a topic that's really dear to my heart. I go way back because I am the grandson of someone with schizophrenia, the nephew of someone with schizophrenia, also the nephew of someone with severe bipolar illness who was institutionalized with psychosis, and the son of a clinical psychologist. So I kind of grew up with it, and I always wanted to be a psychiatrist until I went to med school and kind of found that I wasn't enamored with the psychiatric community and the way they were doing things. However, my hand was forced when my son developed schizophrenia when he was 15 years old, and I really found that I couldn't get the care that he needed and deserved. By trade, a nephrologist and a gerontologist, but for essentially the last 14 or so years, I've been progressively and actually exclusively taking new patients and just people with serious mental illness. So I've basically developed a new field that I have self-entitled psychiatric internal medicine, where we do something radical. We take care of the entire patient using the most effective treatments, and don't just take care of the patient and say, look, I'm not going to worry terribly what you consider your diagnosis to be, and let's see how far we can get with meaningful recovery. And what I found out over the years doing this approach, and we now have, I think it was at last count, 187 people that were involved with onclozapine, which is the gold standard antipsychotic, and as I said, the drug of choice for these illnesses. We have most of these kids in actual meaningful recovery. So when I was told my son would not have a life, I found it unacceptable. When my son got better, he's now a stand-up comic in New York City, and we can refer you to some of his stuff on YouTube, Daniel Laitman. You can look him up and find him. He's actually very funny. I actually just got another joke on Colbert as well. So we were told that my son was the exception. So that started us on our journey, and my son was not the exception. We found that, this is an approach that works. So our perceptions and the perceptions of the psychiatric community and the community at large needs to be changed. And I'll shut up. That's enough.
Thank you very much. Shannon.
Hello, everyone. My name is Shannon Coleman Cryer. Todd, thanks for having me this evening. I am an individual that has bipolar 1 disorder along with a number of other mental illnesses. And I am here because I wanted to share my experiences with you guys. And I am just proud and happy to be a part of this today. So thank you.
Thank you very much, Shannon, for coming to talk about this. To start with, let us jump into the change. I mean, if you go back to looking at something like One Flew Over the Cuckoo's Nest, that with somebody who was for aggression was treated by having a frontal lobotomy, that was not unusual. And I think that at the same time, because it was in a lot of ways, it seems in that show particularly, to be thought of, like you were saying, Robert, about your son as being uncommon. And today, I don't know myself, is that even done today? What has changed if you look over the last 50 years in the mental health treatment world, but also in just the acceptance of getting treatment? And maybe the acceptance of getting a treatment is a question for Shannon. But so let's talk about the change to begin with. What has really changed from Cuckoo's Nest to today?
Who do you want first? Because a lot.
I know there's so much in it.
I mean, a tremendous amount has changed. I mean, back again when my grandfather was in the room, and he was a very religious Jew, and he was having a minyan, which is 10 Jews in a room praying, or so he thought, because he was the only one there. But he was hallucinating, and we were ashamed of this. And this is again with the background, my father being a clinical psychologist. And actually, when divorce was very rare, my grandfather was divorced from my grandmother. So my grandfather, Paul, I barely knew. I knew him as this very, very strange old man muttering to himself, who really I could not make any connection to. And that was, we thought, the best that we could do. This was in the 50s, and I only knew him he died in the 70s, in 1970s. So there wasn't really much available, and he never sought or accepted treatment. My aunt, on the other hand, who was institutionalized, also in the 50s, early 60s, lithium came on board. And so I saw the miracles that we can have. My aunt went on to live a very successful life, became actually a psychiatric social worker in the early days, had a child, and really had a full career, and just passed away in her mid-90s. My uncle, on the other hand, kind of followed in my grandfather's footsteps. We was never able to engage him. He never accepted his illness. He didn't have as severe a form of psychosis. He was accepted in the family, but he was like, there's a picture of him walking across in the background at my wedding, kind of like Alfred Hitchcock in the background, a man with a hat on and looking very strange. So that was the picture I had. My father was a clinical psychologist, but he took care of more of the worried well. He really didn't have that many seriously mentally ill people. But going into medical school, I was taught, and in residency, we were taught these people really were not people that you could make better. They really would never have a life. The only thing you could do was keep them out of the hospital and ease suffering. I was taught, and this is the days before the atypical antipsychotics, that the way you get people better was to make them Parkinsonian. That's what we used as a gauge. We would give them enough of these first generation antipsychotics to know that once they were shuffling, and couldn't move very well, we had blocked enough of the dopamine that presumably the antipsychotic would be effective. In other words, you were getting 60% or so blockade. And that's the background I went through into the early 1980s. You know, coming back, I was disillusioned to see that a lot of the psychiatric community had not changed. And this is when my son was sick in 2000s. And they're still saying he has schizophrenia. They didn't want to use that term because that term automatically, at least was expressed to us, that his life was over. Don't expect him to graduate from high school. Don't even think about college. And then when we dug deeper and we got people that actually knew what they were talking about. We were very blessed to get into connection. Really, it was pure serendipity. We were introduced to a woman by the name of Deborah Levy, who unfortunately just passed away last year. She was head of the McLean Hospital Psychology Research Lab, which has really been considered, and deservedly so, the foremost psychiatric hospital in maybe in the world. And she said, your son can get better, but you have to be aggressive in the regimen. And she was right. And then we were introduced to other people, and lo and behold, it's an education. Like when we had our son develop his illness, we would talk about it freely, and people were shocked that we could just talk about it. I said, it's like any other illness. It is a neurologic syndrome. It's very complicated neurologic syndrome, has neurodevelopmental pathways that we're only starting to fathom now. But there are ways that you can make people better. So things are changing, but it's really, you know, it's I think the rest of the world is way ahead of us. You know, Europe, Australia, especially the Scandinavian countries and England are way ahead of us in the way they handle a lot of these people. I mean, Australia, they start treatment protocols where they don't see the bane of our existence, which is something called anosognosia, the unawareness of illness. They just don't see it because they track people and they know who is a high risk for going on to developing serious mental illness. We know this as well. We can track these people. We just don't do it in the United States. We don't give the resources. They have things called headspaces, which are things that are a part of the school curriculum. This is mostly Melbourne. It's not universal across Australia, though it's starting to be. And they get early treatment, and they use the best medications as early as possible, and they support them. They give them housing, they give them the proper support, and they keep them tied in to you know, the things that people need. And so they realize people can get better. We're just starting to get there.
Wow. Let's, Janet, would you talk about, excuse me?
Oh, I'm sorry.
Oh, no.
Can I
Janet?
add to Dr. Roberts'
Yes.
comment?
Yes, Sean.
Yeah. So I totally agree with you in regards to the idea of we're learning more, and there's more treatment out there, but I don't see a lot of change in the perception of individuals who suffer from serious mental illness. And thank you for sharing your story. You talked about your family's challenges throughout
Right.
40, 50 years. The thing that
Hey,
was
thank you, 60 plus years.
60,
Thank you, Sean.
the common thread that I kept hearing was, you know, it was kept underhand or below or beneath, or no one wanted to discuss it until you run into someone who is aware or capable or knowledgeable about what can actually be done. The work with your son sounds amazing, but I'm sure that had a lot to do with you and your family and putting forth the aggressive treatment and being okay with the idea that this is what we need to do.
Right.
The average American is not very open or at ease with the conversation of mental illness, which is really interesting. You know, when and I'm off on the stats a little bit. Is it one in 1 in 5 Americans will suffer from mental illness.
Yeah, but that's mental illness. I'm where I go from, and I think well, I'd like to keep it focused on the serious mental illness. So more like 1 in 20 to 1 in 25, or somewhere in that range, I think is
Yeah, that's a
it's still a
huge,
lot of people.
yeah,
11 million people, easy.
that's a
Yeah.
huge population
It
to
is.
ignore.
Oh, absolutely.
Mhm.
Oh, and I agree with you. I think, the general population, they're still shocked. And I'm quite so open, and I always present myself. I said, for the love of God, I could have been on the other side of the desk sitting there because, when I was growing up, I was a straight A student and all the rest. And I had a dramatic decline in my academics my junior year of high school, 16, very similar to when my son presented. I just got lucky. I started to do my best Forrest Gump, as Janet Hayes knows, and started to run. And I've been running ever since. I run 50 to 60 miles a week, which is probably not normal, but it's been my mood stabilizer. And I've never really been depressed a day in my life, a little hypomanic maybe, but never mania and never requiring any psychiatric meds. But I got lucky. I
Right.
got lucky.
Yeah, that idea of lucky,
Oh,
having an ability or a skill that you can utilize. I talk about my students. I talk to my students about this all the time. When we talk about quote unquote mental illness, look at the idea of someone just simply seeing things in a different way. And the individuals we treat are the ones who, for whatever reason, can't utilize their skills to benefit society. Whereas someone else who may um, have an affinity for numbers, but lack the social skills,
mhm.
their ability will be seen as advantageous in some way, shape, or form.
Yeah, what's really cool is when you build up my kids, and I call all my patients my kids. Some of my kids are in their 70s, but some of them go all the way down to 14. I kind of have a range. What's cool about a lot of the kids, especially the quote unquote bipolar population, this is really a psychotic spectrum disorder. A lot of these kids really have some incredibly unique talents, and I always try to channel them in that way. And especially some of these kids have amazing amounts of empathy, which you would, which is absolutely against what is considered the standard, because people with schizophrenia are supposed to not have any theory of mind, never get theory of mind, not be, in other words, not be able to really appreciate what other people are thinking and really be able to put themselves into their places and therefore show empathy towards them. But my kids are amazing. You should, and I'd love to get you onto some of my Zoom sessions where we have a Zoom session where we have every Saturday I take the parents and we spend 3 hours just kind of taking people through what they're going through. And then that's followed by the kids themselves interacting with each other. And they're really kind of cool to watch. I'm a gadfly. I'm on the wall on their session.
Can I jump in, Todd?
Definitely.
Thanks. This
Please.
is really interesting conversation going on. I think that I'm loving this between Sean and Robert. In that, I think the idea is that we want, and when we look at individuals, that we want to help the individual, to be able to achieve their goals in life to the maximum that they're able to, for whatever works for that individual. And I think since the cuckoo's nest, we tend to, as a society, we tend to, in our dialogues, put people into groups. And a lot of time there's good reason for that. And I think Robert is, as a doctor, an exception to the rule, in that he is looking at holistic healthcare. So not only, the lowest dose, least restrictive, I guess you could say, medication that, for the individual, in order, that has the least side effects, and then also continuing to work with that individual to not only connect them back to themselves, but connect them to their community and to their lives and to their careers. And I think, for some individuals, medications aren't needed at all. I mean, there are individuals who I think maybe we look at as different, but don't need treatment. And that's
don't need
fine.
medical
They're
treatment.
achieving, because they're achieving their maximum potential without it. Now to try to force them into treatment if they don't need it is ridiculous. I mean, I just, think that
Agreed. If they're living a life of meaning and purpose and they're not suffering, look, the meds aren't that good. They're just not that good if they're already at that stage. Yeah. So if someone's hearing voices and has nothing else,
right.
there's no way I treat that person with a medication.
Right. And I think, a lot of the problem is we just don't have a system that caters to treatment for individuals that are, he'd use the word suffering, but, they really are suffering with, a lot of people are suffering with illnesses that aren't their fault. And we punish them for it. I think as far as perceptions, part of the reason that we perceive mentally ill people as a problem, or we just ignore them altogether, is because we don't see when people are in treatment that they get better. I mean, I know when Robert too, and sort of circles that I'm in, I see that when people are able to get good holistic treatment, continuity of care, that they're able to succeed and able to achieve their life's goals. I have a good friend, Eric Smith, who's an advocate and someone with a serious mental illness. And, he once he was in treatment, was able to continue with his life. He's actually on the medication that Robert promotes, clozapine, but is now doing his master's in social work. He's really done amazing things, but without treatment, he had been in jail and was probably destined to go back there, just because the mental illness caused symptoms that society sees as violent, but they were violent. In his mind, he was doing altruistic stuff. He's saved the world from the FBI, and he's gonna, he had all kinds of delusions where he was the hero in his delusions, and he, so in his mind, he's not doing anything wrong.
Mm-hmm.
But for what we see on the outside is violence, or we see inappropriate behavior, nuisance behavior, misbehavior, behavior we consider not normal. And so we say, okay, well, that's not okay. So we're gonna, we need to lock you up. But to the person, I mean, it makes no sense to them. So, it really is, I mean, we need to find ways, first identifying the illness, and then creating that continuum and bringing in a therapeutic treatment team, including family members and those who know the individual, to help the individual with what's best for them, not superimpose on them what's best for them, but to assist them. And in particular, people who lack insight that they're sick, like the population that Robert, or the word that Robert mentioned, anosognosia, lack of insight. And so 50% of people with schizophrenia, 40% of people with bipolar disease, have this issue where because of their illness,
That's in the United
they're not
States.
able to know that they're sick. So if you don't think you're sick, why would you seek treatment? I mean, I always say, if I don't have diabetes, why would I go for dialysis? And good luck trying to get me to go, because I don't have diabetes. But what if I do? What if I have some fatal disease where I need life-saving treatment, but I don't believe I have the disease, and so I'm not going to go seek treatment? So this is really a population that has stymied society for a long time. Before, we used to put them in state hospitals, and then later on they became under-resourced. We let everybody out, and now most of them are in jails, in prisons, or under bridges. And we just haven't done a good job about understanding the phenomenon, about providing compassionate intervention to help them help them get back on their feet and be free enough of their illness that they can make good decisions for themselves. So anyway, I don't want to go on and on. I could go on all day, but leave room for Shannon and others. to hear
I'd
what
like
that.
to throw it to Shannon actually and to get her feedback on this.
You know, I love what everyone has had to say, and I especially love what Janet had to say because I didn't get diagnosed. Hold on. So I didn't get diagnosed until I was 44, 2 years ago. And at the time, I was at the top of my career. I was a federal investigator. I was doing really well. I had graduated from Loyola. I went to UNO's executive MBA program. Everything was going perfect. And then the depression started, and then the mania started, and all of this stuff started happening, and I didn't know what was going on. I couldn't get any work done. I couldn't sleep at night. I was nervous all the time. I had anxiety. I finally went, a friend of mine said, Shannon, you need to go talk to someone. So I finally made an appointment to go talk to a therapist. And within 5 minutes, she was saying, you cannot go back to work right now. I think I know what's wrong with you. We need to get you into some treatment. Thankfully, there was a psychiatrist that was in the office with the psychologist. She had me do some tests. I did the test. It was determined that I had bipolar 1. And it was the worst day of my life because I knew that once that diagnosis was established, I could no longer do the job that I was doing. And that's basically what happened. I'm 46 now and I'm retired. A few things that I wanted to say that I've noticed since I've been retired. You know, we talk about the people under the bridge, and we talk about how people, in my case, have been discriminated against because of their mental illness. That happens a lot. If you're not fortunate enough to have really good health care, or to reach out and have some really good doctors,
Yeah.
or a team like you talked about with your son, then you're pretty much left behind. And that's how it works. You know, I've had people to live with me with mental illness, and they have to go to these clinics over here on the North Shore, and they get to see him once every 3 months. They don't have a support system. You know, they may talk to a psychiatrist for maybe 5 or 10 minutes every 3 months. They never get a chance to talk it out with a psychologist. It's just, it behooves me. I've never been in that situation. Thankfully, I was able to retire from the federal government with full benefits, including my health insurance. So I talk with a therapist every week, and I see a psychiatrist once a month, and sometimes more, you know, but my friends and other people, they don't have that. And I can tell by the way they are that they're not getting the treatment that they need, and they are discriminated against, and people are treating them like they're nothing because they don't understand mental illness. And it happens a lot. Sometimes, you know, I'm from New Orleans, and sometimes I'm driving in New Orleans and I'm looking under the bridges and I see all of these people with mental illness. And it's like, what happened? Where did we go wrong? Where we can't help these people? You know, I see people walking up the street talking to themselves, and I say to myself, this could be me. This could have easily have been me if I didn't have the team, because I always tell people I have a team that works with me. You know, you with your son, you know, I think that's amazing that you were so proactive and you were just like, I'm going to do this with my son. I'm not going to just let him slip through the cracks. I'm going to work with my son. You know, a lot of people don't have that. And I'm going to say this, and I'm sure a lot of people won't agree with me, but in the African American community, specifically where I come from, we don't talk about mental illness. We just don't do it. My mother had it. I recognize it now because obviously I have it. My mother suffered with severe depression, and we never talked about it. When I talk to my girlfriends about what's going on with me, it's like they hear me out, but they really just want me to be quiet because we don't talk about it. We just deal with it. So hearing what I'm hearing today is actually helpful to me because, you know, getting these different opinions and hearing about what you guys feel needs to be done. It's really helping me out a lot. So I don't want to take up a lot of time either. So I'm just gonna bye. Thanks.
That's a great, actually, I loved hearing that, Shannon. I wanted to ask Sean, also, do you think that in the same way that the African American community doesn't talk about it, do you think that that influences the way that doctors or clinics receive African Americans coming for help?
Yes. First, let me say thank you, Ms. Shannon, for bringing that particular topic to the table. Yeah, every culture deals with mental health differently, but in African American community, it is really it's a stigma. You can't talk about it, or you'd be better off seeking some type of spiritual connection or release. And not to say anything again, anyone's spiritual beliefs or cultural beliefs, but there are tools that God put there for you to use, and connecting with a mental health professional will be one of them. And so when you work with the client, when I work with the client, and I believe the individuals on the call would agree, you meet them where they are.
Mhm.
What do you need? What are your goals? How can I be of assistance? As opposed to, this is what you should do. This is what you're going to do. This is what needs to happen right now to move forward. And I think that has more to do with respect, which I think works with all cultures, as opposed to creating or utilizing a kind of standard issue treatment protocol when a client comes in.
Yeah, I mean, I think racism comes in as a huge part of this too. I mean, I've been in the Bronx for 40 years, so I have a population of, as diverse as you can get, and and you're right. There is that problem in, I've a very, a good percentage of my kids are kids of color, and breaking through into that, and I'm luckier because a lot of the kids came to me because they heard about me in the community, and their parents were nurses, so they were very well educated. But it's really hard, or harder, to engage. And a lot of these kids have been blown off or have been shut off to the side, especially some of the young men who've had some violence, and they're just treated like criminals. And Janet sees that all the time. I mean, I can't tell you how many kids I've talked out of jail. I've had to go on to my legislators. I say, no, do not put this kid in jail. Just get him back to me. This is early on in the treatment protocols. And it's, they say, really, you'll do that? I say, yes. And you can block, you can actually change the trajectory of these kids' lives. But it's hard, because it's hard to make that connection. And I, one of my favorite sayings is, mental illness is a team sport. So I not only have to engage the kid, I have to engage the family and the community, and often the church, because church is really, so I have a number of pastors that I take care of kind of on the side, just to, so that I can keep them, preaching appropriately, that know that there is a way out of this, that that you do take a full biopsychosocial approach. And but it's definitely tougher in certain communities.
Mm-hmm.
And if you don't have resources and you don't have support, it's almost impossible. And so if
Does
you're
that
out on the street, you're finished the way our society is right now.
Yeah, I definitely see that a lot also in calls that I get, especially when dealing with families of color. It's not until something dangerous happens that they actually reach out and say, okay, I tried and tried and tried to get my loved one into treatment, and I've exhausted all possibilities. They won't take their medications. They don't think they're sick. They've been in and out of the hospital. Now they're in jail. What do I do? That's the most common call that I get. And it's really heartbreaking because I think, as Shanna, as everyone's mentioning, there are things that we can do way earlier for folks if we just know that they're sick. And I think in communities of color, as well as also in Caucasian communities, there's this idea of self-responsibility, personal responsibility, that if we just try harder, we can get better. Uncle Joe's not quite right, but that's because he's lazy, or that's because he just doesn't try hard enough, or whatever. And not understanding that mental illness is just like any other illness that, responds to treatment and responds to, various psychotherapy, and that if we recognize it as an illness, then there's no shame in it. And again, as I said earlier, I think that once society starts to see that more examples of, hey, I got into treatment, I take medications, just like people take medications for hypertension. There are, and this is how we know, I think also, that serious mental illness is often a medical problem, because medications and clozapine, and there are other kinds of medications as well that can really help people with their delusions, their hallucinations, and so on. It may not make them go away, but it might put them far enough in the background that people can function just fine in their lives, even though they are still hearing voices or have auditory delusions. I mean, I think of my mom, who was depressed with severe depression, or diagnosed and depressed with severe depression. I remember going to lunch with her one time, and she was so afraid. She was taking her pill, and she was so afraid that somebody might see her taking her medication. And I'm like, Mom, nobody cares. That as far as they know, you might be taking an aspirin. But she was just so wrapped up in her own fear of that there's something not okay about mental illness or about being depressed. It didn't stop her from getting treatment. She went ahead and she got a psychiatrist, she got a psychologist, she got great treatment. And to this day, she functions very, very well, but she still doesn't want anyone to know, that she suffers with depression. So it wasn't stigma that stopped her from getting treatment, is what I'm trying to say. However, it doesn't help society for people to continue, that are in treatment, to continue to hide it. So I think, more stories maybe, and I know Amy had asked a question about how can the performing arts community help build awareness about these issues, to maybe help quell some of the so-called stigma, we call it discrimination and prejudice. But I think maybe more stories about, hey, my friend Eric Smith, who, was the poster child for the guy who was never going to get better, on a life's trajectory to either incarceration, homelessness, or early death, and got into an assisted outpatient treatment program with a judge in San Antonio who worked with him and a team to help him get back on his feet. And now he is, after a long struggle, pursuing his master's degree in social work. Shannon, and there are people out there who have gotten treatment, and it's like, well, here's what, just giving people a demonstration, a visual, or some kind of artistic depiction of what needs to happen in order for the system to work, for people to get better. I mean, I know it's not as much of a draw as One Flew Over the Cuckoo's Nest, but I guess sometimes a lot of it's just in the PR and the billing, right? So.
Yeah, we've gotten a little better since One Flew Over the Cuckoo's Nest. I mean, really, Ken Casey's novel and One Flew Over the Cuckoo's Nest has led to another national tragedy. It's contributed to, it didn't lead directly, but it's contributed to the transinstitutionalization of serious mental illness. And it pointed out many fine things about how horrific these sanatoriums were. If you go way back to Dorothy Dix and the days of sanatoriums when they came in the United States, there were places that they go out and farm, and they were acceptance, and there was community, and there were wonderful places there. Sanatorium was a place to get well. It was like a glorified spa. You take away all the trauma of the outside world, and you just gave them a genial environment. And unfortunately, over the years, money disappeared, and they became back to the usual for serious mental illness, which is squalor and horror. And so One Flew Over the Cuckoo's Nest pointed that out. But as is in America, what we often do is we swing wildly on pendulums. And so the reaction was close them all down. And when JFK said, all right, we'll close them all down, And I've seen, as you mentioned before, the lobotomy, when he lost his sister essentially to a horrible lobotomy, this woman who was really not all that impaired, but then became a total invalid afterwards. He had the right idea. He had the idea, if we're going to close it down, maybe we could get about 50% of the people out. Because you know what? Even when we do everything right, there are some people that need tremendous support and need to be in a protected environment, no matter what. So I don't want to be Pollyannish about my approach. I can make everyone better than they were, but can I make them well enough to live an independent and full life? No, I really can't. The diseases are so varied. Um, so we do need to put our supports in place. And so when Kennedy died, and basically all the funding went with him, um, we've seen just a tremendous shrinkage. We'll talk about, Janet can talk your ear off about the IMD exclusion, which has been one of the prime movers. Basically, they don't pay for people being in IMD is Institutes of Mental Disease. And it was 18 beds or is it 16 beds? I always forget. It doesn't matter.
16.
16 beds. Yeah, if you're over 16 beds, Medicaid will not pay for you. So all the care, all the care or the cost was shifted to the state. So what is the state going to do? State's going to close down that institution because it's going to bankrupt them to take care of these people. Where do these people end up? Janet will tell you, jail and in the street. So that was one flew over the cuckoo's nest. At least they had a place to sleep. I mean, Nurse Ratched wasn't exactly a model citizen, but we've gotten a little better there. Arsenic and old lace. I don't really know arsenic and old lace. I know the perception was that I think there were two characters with severe mental illness. They were kind of not listened to or shuffled to the side.
Well, there's actually three of them, and actually they sound a lot like Janet was talking about your friend. I mean, the two sisters, the two Brewster sisters, are in their minds doing the right thing. They bring essentially homeless people who have no one else in the world. They bring them into their homes. They give them a place to stay, and then they basically do euthanasia. They poison them and kill them. And because they believe that these people's lives are not worth going on, and they have conversations with them and find out that they're destitute, they aren't happy, they have nowhere else. So for them, they believe they are saving them by killing them, and they're doing it humanely and gently. And then they have the other one can um, dig graves for them in their basement, and so it's uh, he who believes he's Teddy Roosevelt, and so but in their minds they believe they are not doing anything wrong. They are truly believing they're being helpful. But what we kind of said earlier is that even whenever the nephew tries to tell the police there are dead bodies in the basement, go look. And they say, oh no, how dare you say something about these good Christian women? They never would do something about that. But it's exactly what you were talking about. They aren't mean. They don't believe they're being mean, although they're murdering people. And in fact, at the very beginning, there's a dead body in the living room that they need to get downstairs, and they're worried about him having a proper burial. And but again, this is not appropriate behavior to be killing people. And but
I think we can all agree on that.
yeah, I mean it's. But I want to go back and grab a little bit topic a bit earlier, and I think this is connected with Sean teaching, and because I wonder if, and I don't know this, but is it more difficult for people in minority communities, people of color, Hispanic communities, to go talk to somebody that they can't believe that they can trust? Is it, does a person of color, if they had more doctors who were of color, would it be more trustable to go to open that conversation, open one's soul? I mean, you're teaching tomorrow's teachers and tomorrow's doctors. Do you think that that's an inhibitor for the communities?
So, interesting topic, and I want to address that, and I want to address a statement that my colleagues made earlier, and that you mentioned earlier about the value of the individuals that we're working with. Um, they have a, I hate to say this, the consumers have a dollar value when they're in a hospital or when they're in a school. There's a dollar value attached to those individuals, and when that dollar value drops, the systems as a whole say, okay, this person is useless. And then an example you gave, I guess they're useless, so useless you can kill them. Um, that idea of someone with mental health issues not having value, it kind of flows throughout our culture. And I always saw this connection between mental health and the arts as a whole, because when the country is having financial crisis, you'll see, and education as well, you'll see funding come away from mental health services, you'll see funding come away from education, and you'll see funding come away from the arts. And it's always the same thing. When you take away from a person's ability to be creative and engage, you take away from their ability to think and to grow and to achieve. So I'm sorry, I'll jump back to your statement.
That's great.
That was going through my head as my colleagues were speaking. But to answer your question, it is really interesting to talk to my students, because Dillon University is a HBCU, and the majority of the students are African American, and they are completely against the idea of working with someone outside of their ethnicity. And I find that so strange. And when I explain to them that, the overwhelming majority of individuals in mental health professionals are of non-white, if you have an issue and you refuse to work with someone outside of your culture, you're out of luck. African Americans make up maybe 2% or so of the mental health profession. So you have to get over that. Um, and someone's skin or background or culture does not make them a healer or a professional. It's their empathy, their education, if they can have the ability to actually meet with you and work with you where you are. So we do spend a lot of time talking to students about challenging that that misnomer, that idea that I can't do it if they're not black, or I can't go into that setting or work with that person if they're not black. And it is a challenge. It is a challenge. So oftentimes I bring in my colleagues from other ethnicities, other backgrounds, to speak with students, to serve as a cultural gatekeeper, if you will, to explore other cultures. I think that's one of the big issues, and I think my colleague was mentioning this earlier about racism, to kind of address that, is when you have exposure to another culture, exposure to another race, it reduces the stereotypes or belief systems that become
Yeah.
barriers.
People are
to that
people.
interaction.
Yeah.
Yeah.
Yeah. It's the same thing with people with serious mental illness. As we all like to be part of the same tribe. So that's always the whole thing. I mean, this goes way back when, I'm a big animal behavior kind of guy and steeped in biology. And so if someone looks different from you, they're not part of your tribe. And therefore, we see racism. But what we really see is someone who comes at you with a flat affect, looking drugged, looking ill. There is that, stay away from me kind of, that you're going to get from the general community. So, there's a lot of work that we have to do. And I think you have to recognize that in people, that there is some hardwiring. This is part of our biology. But the way to get around it is, as you said, get everyone together and make them a community. I mean, one of the dreams I had, would be to have what the Mormons do, a mandatory 2 years where they all go off and we're all in AmeriCorps together. And you grow up with people of different ethnicity, different areas of the country. I mean, we have such a horrifically divided country now. What I've loved just being in the Bronx is, you know, the psychiatric social worker that I have is a lovely Jamaican man, and my another doctor in my office, Dr. Calderon, is Hispanic, and it's really everyone just treats everyone like a person. All of a sudden the color fades away. And what's even cooler is the people with serious mental illness, when they first were introduced in my practice, remember I came from an internal medicine practice, then my geriatric patients would see all these kids coming in the office, and they'd be a little standoffish. But then as they saw these kids actually engage them and look like ordinary, normal kids, they would say, "Hey, John looks great." And then they would engage them in conversation, just putting people together. And that's where the arts can really come in also, to show that it can work, be it a documentary about Eric or just show some stories that where people treat people, just like themselves. It's really very simplistic approach, but when I have a conversation with a kid, I just treat them like any other kid, and I think the advantage I have is that, as I said, I could have been on the other side of the desk, and I have a son who has psychosis, and I have all these relatives. So I said, look, biology, it's all biology. Let's just work together and see how great you can be, and I have faith in you. And right there, that breaks down a lot of barriers.
It kind of feels like exposure therapy. Like it sounds like you have a wonderful melting pot of a community, but some other communities are quite isolated in their silos. So when you can see a movie or go to a play or engage in some type of artistic expression and see another side, it does give you that exposure, which right now, the way the world is kind of set up, exposure is something we've been pulling away from a little bit, which is really dangerous.
Yeah.
Agree. I think also, yeah, and also I think we need to deal with the suspicion, and communities of color have been horribly impacted in the past from awful experimentation and various other injustices and crimes that societies have committed as a whole, and really not paid for it, but that's real. And I hear about it all the time. So the white coat is another, when we talk about how we appear to others, the white coat represents something to a lot of people, regardless of who's in it or what color they are. So, that's a medical issue. It's, fear of the medical profession. And, it's not just mental illness, it's all of medicine. So, there are a number of huge issues that need to be tackled, but I love that, Eric, about or Sean, sorry, about your analogy to exposure therapy. I love that. I think, yes, the more that we are exposed to one another and realize that, we all have the same love, hate, fear, human, needs, food, water, those things that make us a civilization, that the more that those other divisions will start to fade away. But yeah, we are so divided right now. How do we bridge these gaps. We've become, I mean, this, especially the United States, just over the decades has really become more and more and more divided. And, where do we start to begin the unification process? We can't unify if we keep swinging at each other. We could talk about it. We all need to be unified, but I'm going to throw this bomb at you while I'm saying it. It's just, I think, maybe we all need to take a little Xanax as a society and calm down a bit. But anyway, it is interesting to explore how the arts can be a part of this, of a more of a, sort of unification and coming together and getting us more on a path of recognizing each other for who we are and meeting each other for where we are and making sure that our needs are met, whatever those needs might be, including medical.
Shannon, you want to jump on this?
I'm sorry, were you referring to me?
Yes, Shannon.
One of the things that I thought about, Todd, when you said how can you guys help? Tell the story, but make sure you tell the story accurately.
Right.
Talk to the people that actually have mental illness. Talk to the professionals. Speak to people like myself who are impacted by mental illness. I know that ultimately we want to entertain people. I went to a show when I first got diagnosed in Arkansas. I went to a show and it was funny and it was hilarious, but it had nothing to do with bipolar. It was funny, but it made a mockery of bipolar. It was not what it was supposed to be. And I left there really hurt because I suffer from this. This is something that has taken away my career. It has impacted my family. It has impacted me. It has impacted everything. And it's not anything to play around with. A couple other things that I heard too about the dollar value. It is so true. It's so sad, but it is so true. I remember going to having psychosis and being sent to a place in Covington, a doctor's office in Covington, a hospital in Covington. And when they found out who my doctors were, they sent me home. They didn't even want to help me. And I needed the help. It was not safe for me to be home by myself. And they sent me home. They just sent me home. And it was terrible because my husband had to take off work for a week to stay there with me. And I didn't even know what was going on. I had no clue what was going on. It was the worst that I had ever been. And it was just the absolute worst. But it was what happened to me. That was my experience. And so when I think about other people and what's going on with, I have a friend that has bipolar disorder. She has bipolar 1 as well. And she and I talked yesterday and she said, Shannon, it's so funny how you're on designer drugs and I'm on the drugs that I'm on. And I keep getting mania and you don't. And I don't understand that because I keep asking the doctors, can I get on your drugs? And they laugh at me because I can't afford the drugs you take. And it's sad because she has Medicaid and I have federal insurance. So of course I can afford to get the designer drugs and she can't. And she's in a bad place. Unlike me, I'm kind of stable and she's not. But it all comes down to, in my opinion, with this community, especially out here on the North Shore, to me, it's all about what you have, really. If you're fortunate enough to be someone that has really good insurance and you can advocate for yourself, you're okay. But if you can't and you are on Medicaid or you don't have any insurance, you're screwed. And that's just the reality of it. So many people have fallen down and fallen by the wayside because they don't have anything. And that's something that if you are going to tell the story, that should be a part of it because it is the reality of it. It is truly the reality of it. There are so many people who need help that would love to get help, but they don't know where to go because all their lives they've been turned away and turned away. And that's not been my experience, but I know a lot of people who have gone through that. And I also remember being in the hospital, and this is so funny. There was an African-American lady there. She was one of the techs. And she said, "What are you doing here?" And I said, "I don't know. This is where my doctor sent me." And she says, "Girl, you need to get out of here. This place is not for you." I said, "What do you mean?" She said, this is not for you. You don't need to be here. You need to be in a country club type situation. You don't need to be in here. And I remember thinking, like, I need help too. You know, I really need help. I'm going through these psychosis. I'm talking to myself. Things are going wrong and I need to be in this place. And then everybody started treating me like that. And it was terrible. So, I mean, I've had some jacked up experiences is what I'm trying to say. I've had some really jacked up experiences. And the other thing I wanted to add was I have never been able to find an African-American psychologist or an African-American psychiatrist.
Thank you, Sean.
I've just not been able to find it. And I've looked because my first psychologist said, maybe you would feel more comfortable with someone of color. That may help you to be more open and open up more about what's going on with you. And we looked and I couldn't find anyone. So it's unfortunate, but that's what I've still, right now I have a social worker that I'm working with because my psychologist, Sarah Tester, she has retired. And so I have a social worker that I work with now and we do therapy together once a week. And she's African-American, as I said, but she was the only person that I found and she's in the city. But really, there was really no one that I could reach out to that was a person of color and say, you know, can you help me? So that's just been my experience.
Yeah, I think it's only like 4% of psychiatrists are African American, or maybe it's 4% Hispanic and like 5% African American. I know that in the Helping Families in Mental Health Crisis Act, which was a bill introduced by Tim Murphy, who's now he was congressman from Pennsylvania, now retired. But anyway, he introduced a bill that a lot of people went to bat for because it was the first time that mental illness had become a national conversation again, really since John Kennedy. And so there was a provision there for fellowships for people of color to be able to pursue degrees in psychiatry and psychology. And to my knowledge, that never didn't pass. It was so we got a lot of provisions passed in the 21st Century Cures Act, but we have a long way to go. But I know also that I think there are limitations on the number of psychiatrists and psychologists that universities pass every year. So there would, I think having those incentives, for universities, to first of all create more positions for psychiatrists who want to graduate or people who want to take psychiatry, but then also to provide those fellowships would help a lot. And I agree completely with the value-based value discrimination in terms of who gets funding and who doesn't, and who has access and who doesn't to, not only psychiatric care, but also the medications that Shannon talks about. It's a very real thing. But I do also know, and I'm glad that Shannon mentioned families, because families are also a huge part of this conversation and often get marginalized and painted as the bad people, when really they're doing everything they can to help treat and care for their loved one who may not want it. And so, in general, I think, yes, people who are better resourced obviously have more access to getting treatment when the person wants it or when they want it. But when they don't, believe me, they're all in the same, can of worms as everybody. And that, if somebody doesn't want treatment, it doesn't matter how much money you have, you can't convince them that they need it. So, we get a kind of a mix of people who call me who are in mental health crisis, mostly for that reason. It mostly has to do with the loved one doesn't want treatment. They've exhausted all other possibilities, and now they're calling me. And I do my best to help, first of all, help the family navigate the situation, so that they understand what's happening on the criminal justice side, if that's relevant, and the behavioral health side, and where the brokenness is and why they're experiencing what they're experiencing and not being able to move the ball, right? But then to also help provide them with solutions, whatever solutions we have. And sometimes we can help and sometimes we can't, but I'll tell you what, we sure turn a lot of people into advocates once they recognize where the breaks in the system are.
I'm fond of saying that there isn't a system because there really isn't. I mean, so even, right, you guys are really handicapped if you don't have the ability to access, and therefore you can't even start. So I always say my EATS acronym, it's engage and educate, that's one E. A is for access, T is for treatment, and S is for support. You don't have all of those components, you're really not going to get the treatment. That said, I'm in the Bronx, but I also have Westchester, Nassau, tremendous communities of wealth. And you wouldn't believe how bad the care is. So everyone always says, oh, access to care, access to care. But there has to be an education in the psychiatric community about what is appropriate care. I can't tell you how many hundreds of thousands of dollars of wasted, just total waste, sent off to the adventure program, pull yourself up by your bootstraps. These poor kids get tortured in the most inane ways, sent off to Florida where they're denied, the basic necessities of life and, taught the tough way to, fend for themselves. There's so much crap in the psychiatric mainstream. So, we have a lot of work to do there. So we not only have to recognize that we have to have the ability to engage people, and if people don't recognize they have illness and are severely impaired and are a harm to themselves and are suffering, they need to be brought in usually by court mandate because we have no other way of doing it right now. And that is a potpourri across the country where it exists county by county and is different in every area and is underutilized and poorly understood. And, it's an opportunity to get someone well if you can engage them in that way. And then access, you're right, especially in the communities of color, there's no access. There's no one there to treat. So we need to involve people that we can, and the way you can get people into access is make it an appealing subspecialty. It's like my wife is also a doctor. So we are a practice, the two of us doing this together. And I brought her initially kicking and screaming into this. And now she also loves it because as an internist, you can get people better, but it takes a long time. You give a cholesterol medicine, I might take care of the family for 30 years. Yes, they're sailing along doing well, but you could turn someone's life around in 6 months with appropriate treatment. And it's really a glorious thing. So you would expand access if you can get, especially, the community that we're talking about here, the community that is in film, because that's where you really engage people. You show that people do get better. You show the general community, and then you're going to get more people going into these fields. Movies like The Soloist, which we're not mentioning, I thought was great, or, oh my God, Beautiful Mind. There are some inspiring movies out there that show. I just saw a movie, Afraid of Rain, I think it is. It just came out. It actually was not terrible. It was kind of an interesting movie. It was, but again, anything to improve access and then treatment. Janet knows. I just believe in using the most effective treatments in a wraparound fashion. There's nothing magical about taking care of a person and engaging the person and doing a full biopsychosocial approach. Again, therapy and medicines, the whole thing running. I have a charity, Team Daniel, running for recovery from mental illness. I emphasize running because if you're going to look at it and you're going to compare it to medicines, especially for depression, it's almost as good or better in some settings. And it always adds, we talk about diet, we talk about all that. And then we get to Janet and we need the support, we need housing. So we kind of know what we need to do, but we have to have the resources and we have to educate everyone. And that means the families, the psychiatric community, and the general public. And film could do a lot of that.
Mm-hmm.
If I may, want to jump in and just speak to a statement Ms. Shannon made about difficulty finding the provider of your choice. I think my colleagues were mentioning this as well. So it's difficult to find a resource to have that access. You may have to loop other non-traditional means of access into your pattern. So instead of, which is difficult, just contacting your insurance provider or connecting with your local community or friends, include places of higher education. So for instance, you're saying, I'm having a difficult time finding an African-American psychologist. In the institution that I work in, there's 7. And then I have colleagues at Xavier, colleagues at Tulane and Loyola. So, we exist. It happens. But as my colleagues were saying, getting that direct route can be challenging. And sometimes you have to integrate those other components into your toolbox. Not, come to the school. And I know that may be challenging, but events like this where we can meet face to face and talk and learn about resources and connect with each other. And in regards to the arts, I was thinking my students oftentimes mention how interested they are in psychology because they had, again, exposure to someone or a situation that said, this is something I want to do. My family member suffered from mental health, or I struggle with mental health, or I saw this in a film and I find it really interesting. I saw this in the film, and Dr. Robert brought this up, where I saw an African American suffering with mental health, and like, wow, wait, I can do that. Or which I think is even rarer, seeing an African American or a person of color as the doctor. And then when you see that, which I would love to see more of, in film and in theater and in the arts, it sends that message of it's okay. There are other people out there that you can reach out to and connect with.
Wow, I don't think we've even begun to scratch the surface, which I'm sure we'll all agree with. Um, but I want to thank you all for talking today. I think that there's a lot of conversations to have going forward, particularly today with what everybody's going through. And hopefully we're at the beginning of a real renaissance and whole human care. I think I love that premise that we've all touched on. As I have a friend who says that they don't understand. Actually, a friend who talks about this, referring to alcoholism, to say, why is it a bad thing to be considered bad to be treated for alcoholism when you wouldn't have any problem saying you're going to go see a doctor for your kidney or your liver or anything else. And same thing with mental health. I will say that my therapist is an African American woman. Okay, by the way, just that, and which is something. I mean, I just signed up, and that's who I got, and she's wonderful. I've been with her for over a year, and it goes back to she's a human. She understands emotions. She understands situations that I can't see in myself, and it's amazing. It's her job. It's what she's trained to do, and has nothing to do with race at all. And so it's not a, but I understand. I wish more people knew her. I mean, she really is amazing. And but I hope that we can have more conversations because of you're right. The arts have a lot to do. A lot of artists. I mean, if you look at people. I mean, you look at artists. You have Kurt Cobain just coming to my head. Kurt Cobain. You have Robin Williams. All of suicides that have happened. Drug overdose from depression. So many people in the arts. If you go back to Van Gogh, people who have been affected by mental illness and who have used who have their mental illness and their depressions have created their art. And today we are entertained and our emotions are moved by their emotions that they put into their art. So I think that there's a great connection with that because unlike a kidney or a liver disease, your emotions and your brain are one. And I really hope that we can continue the conversation and find more ways to bring awareness. Because some of the things I heard today, I had never heard before. And Shannon, I think Shannon's still here. I want to thank Shannon particularly for being as willing to share about this. But again, if we're saying where is the embarrassment in any of this? I guess none of us. I shouldn't be ashamed to say I take Paxil, and so got to get that changed because it ain't working. But that's another topic. but you know,
for Sean, in Afraid of Rain, the psychiatrist was a woman of color. So in the movie, so there you go.
I gotta go with this movie. Well, thank you all very, very much. I would like to, at some point in the future, I want to continue this conversation because I think it'd be great to use what we do to not just become entertainment, but to be a real door to have deeper conversations about the people in our communities. Okay.
And thank you for inviting me. I really
Oh.
enjoyed meeting you all. Shannon, Sean, Todd, Janet, I know. Amy, thank you.
Absolutely. I mean, Sean, Janet, Robert, thank you all, and Shannon. It's been a pleasure, and I look forward to talking to you all again soon.
Thanks, guys.
Thanks.
Thank you all.
Bye.
Bye-bye.